And today I have with me Dr. Sheldon Ricklin, who holds the Peter O'Cooler MD Endowed Chair in Health Disparities and is an associate professor in the Department of Family and Preventive Medicine. He is one of only two Marshallese physicians to complete medical school and residency training from the U.S. accredited programs. And Dr. Ricklin trains residents in the Family Medicine Center on UAMS Northwest Regional Campus and sees patients at the community clinic in Springdale, offering culturally appropriate care to the clinic's Marshallese patients. So, Dr. Ricklin, thank you so much for joining us today.
Yeah, well, Robin, thank you for having me.
So let's dive right in. Healthcare providers and others that work with Marshallese must understand the cultural history and health disparities. Tell me what those are.
Yeah, if you do not know who the Marshallese are or the Marshall Islands are, I think it's best for your best interest as a provider to be able to kind of provide culturally appropriate care by understanding exactly where they're coming from. Why is it that there are Marshallese here, whatever state you are in? But, if we're talking about Arkansas, why are there Marshallese in the state of Arkansas? Why are they not back in the Marshall Islands? And what's the significance of that? But really, the Marshall Islands, basically we're about 2,500 miles to the southwest from Arkansas. So we're in the middle of the Pacific Ocean, very different environment than it is here in Northwest Arkansas. We're surrounded by the big Pacific Ocean. So the challenges in terms of, providing care there are a little bit different from here, but also our history, especially the history of the nuclear weapons testing program in the islands back in 46 to 58 kind of present other challenges as well, or additional challenges, especially when it comes to healthcare, whether it's diabetes, whether it's heart medicine, or whether it's high blood pressure, or even cancer care. So I think just understanding a little bit more that we come from a different place, that to address our needs, you're going to have to kind of think a little bit different than how you do with everybody else.
So what is culturally appropriate, and how would you describe some of those quirks that many of us don't understand?
Yeah, I think culturally appropriate is, you understanding and respecting your patient's culture, where they're coming from, and understanding that some of what they do is different and may not look normal to you. Many people think that, when you, out of respect, when you speak with somebody, you need to have that direct eye contact. And sometimes there is this misunderstanding that because we're not looking at the provider's eyes all the time, we're always looking down, we're disrespecting them. And actually, it's the opposite. Out of respect, we're not looking directly at their eyes, but we're actually looking down out of respect that, you're my provider, you're my doctor, you're my nurse. I'm respecting you by doing that. So that's one example.
What do you believe that medical schools, residency programs, clinics, and other healthcare providers should understand about the Marshallese and other Micronesian patients on how they do things differently that can be viewed as negative? You mentioned eye contact. What are some of the others and the reasons behind those?
Absolutely. And for those who don't know who the Micronesians are, so if you really look, you can even Google it, but you look in the Pacific Ocean. So the Marshall Islands are in Micronesia, just like Hawaii is in Polynesia. And then besides the Marshallese, there's other groups like the Chukis and Pohnpeians and Micronesians where we're similar in that aspect, but we also have very different culture and ways. But many of the things that we do is a little bit different from what happens here in the States. We're more relaxed, easygoing people. We're not in a rush. I always try to, I tell my students and others, I say, the Marshallese are the coolest people because we don't rush. We just stroll through life. So when somebody comes and passes us on the street, that's because, that's not Marshallese. But we, they kind of stroll. So we still get to our appointments. Most of the time, we're a little bit late. Sometimes we're very late, but it's more out of that, the culture of way that we were brought up in the islands. In the islands, things are more easygoing, just like that.
What is the trauma history and cultural aspects healthcare providers should know?
Absolutely. That's a great question, actually. So for those who probably do not know, but this is information that's really not in the textbooks. And this is information that we're always trying to kind of teach others about us. And, it's really not in the history books at this point, hoping that it would in the future. But between 1946 and 1958, the Marshall Islands were used as a nuclear weapons testing ground by the US. And the United States actually conducted 67 atomic bombs in the Marshall Islands. And everybody knows about the Hiroshima-sized bomb, right? Hiroshima bomb. Well, equivalent to all those 67 atomic bombs, that's equivalent to about 7,200 Hiroshima-sized bombs. So that's a lot of yield of nuclear weapons. That's equivalent to more than one atomic bomb, Hiroshima-sized bomb, being detonated on a daily basis for 12 years. So you can imagine that. I mean, what kind of destruction that played in the islands. I mean, islands vanished off the face of the earth, but it also contaminated our land, our air, our soil, our fishing grounds. Marshallese, before colonization, were one of the most healthiest people. You would see them and rarely any fat if you look at their old photos. But when you take that away from them and you substitute that with processed canned goods and meats because they're safer, because they're not radioactive, you play into their chronic conditions. But you also still have to kind of deal with the nuclear weapons testing programs, cancers, and all those kind of things that actually came out of the radiation effects in the islands. So you need to kind of understand that, when you address the needs of the Marshallese patients, you also kind of have to kind of look back into what happens with that as well.
What are the social determinants of health that affect this community?
Pretty much all of them. You talk about housing, we're always, looking into affordable housing, high paying jobs. There's issues when it comes with, education. Our educational system in the islands is not the best. Part of the reason we migrate out of the islands is to seek better educational opportunities, to get better paying jobs, and of course for healthcare, because we don't have as good healthcare structure back in the islands than we can actually get here in the US.
And language is a major barrier. Before we started recording, I asked you how to properly pronounce your last name. And I know that I butchered that name in the pronunciation. I'm so sorry. So from pronunciation to understanding the language as a whole, that is a major barrier. What should healthcare providers and community partners do? What could they do to make that better?
I mean, anything that has to do with accessing any kind of services, you got to understand it. Not just understand it, but comprehend it and apply it, utilize it the way it should be. But if you don't speak the language, it's really hard because, if I'm trying to get to a healthcare clinic because I'm sick, but I don't speak the language, I'm embarrassed, I'm ashamed, I don't know how to access it. And if they don't have anybody there to help me translate or interpret my language, then I probably wouldn't go there unless I really get sick and I go to the emergency room. I think as providers and any institution that likes to think of themselves as community-based organizations or community organization, whether community hospital or community school, if the Marshallese are part of your community, then their needs should also be addressed. And one of the best things you can do, especially to address the needs of the folks there, is actually hire somebody who's Marshallese. If other Micronesians, hire somebody who's Micronesian. Because, we know that, if we see somebody who's Marshallese who works at the front desk or is answering call, we're more comfortable to come to your place and seek the assistance or resource that we need. So just even having that one person and even hiring more than one, and even attempting to say the name Rickland, even attempting to say something in Marshallese, we accept that because, for us, we know they are not comfortable saying it, but you're doing something to make us feel comfortable.
And health insurance is also a barrier. It's tough for all of us to navigate, and much less the Marshallese community. Can you explain how healthcare is provided in the Marshall Islands and how that relates to the challenges faced by the Marshallese community here in the U.S.?
Absolutely. And, I think that's also a great question because in the islands, there is really no insurance base. And, so I think, people need to understand that, when we have Marshallese patients or micronutrients patients come to your clinic or hospital, the concept of an insurance is foreign to us.
The pandemic is unwinding and presents a lot of challenges for healthcare providers. The clinics, hospitals, and other healthcare institutions seem to be going back to the way that they were pre-COVID in a lot of ways. What does that look like, and why can that be a problem?
Yeah, I think, COVID, devastating as was, it had a few silver linings in it, where really before COVID, many of us, Marshallese and Pacific Islanders, were more invisible to others, um, especially when it comes to healthcare or the needs of resources. COVID really kind of brought us out, where the number of the Marshallese, especially here in Northwest Arkansas, the numbers were just disproportionately more than others when you compare us with other racial and ethnic groups, even if we make a very small percentage of the population.
And there is still an ongoing migration of the Marshallese community to the United States. It continues to grow, correct?
That is correct.
And it's not going away. So the community is growing locally and in other states. So how do you think healthcare providers can help?
It definitely is not going away. I was there recently back in April and also last year, and you go to the airports, especially in the Marshall Islands, on Major or the capital city, as they're flying out of there to come to Hawaii and then go to the separate ways. There's always people there, and people are basically leaving to come to the States. Many of them come to Arkansas because we have a large community of Marshallese here. They have many other family members who are here. The cost of living is definitely better than other states. They can have better access to education, health care, and get jobs easier. So they're still coming. Besides Arkansas, Washington State definitely, and Oregon and California and all Enid, Oklahoma. There's more and more of us are coming out here. So if you really need to address their needs, it's basically to be culturally cognizant, cultural humility, basically understanding your beliefs and values and how do you address the needs of those who are not like you, who are the Marshallese, and how do you address that? I think if you, with the mindset that you're going to address their needs because they're members of your community, they'll be healthier members of the community if you address their needs, and they'll be even more productive members of the community. And you would find that the community that they are at, if they're healthy, is going to flourish. And, with the richness of the, bioculture aspect of it, especially with the Marshallese and Micronesians.
And you mentioned that it's not just Arkansas. You also mentioned Washington State. So tell me a little bit about programs like Washington State and what's going on in Iowa. They're doing some things that are a little bit different as well that can help address the Marshallese community and help them with healthcare. What are the providers in that area doing to address the needs and the challenges?
Yeah, that's a great question. And actually, it's not the first request that we've gotten. And I'm saying I'm talking about Arkansas, UMS, and some of our community-based organizations as well. But, we keep getting requests from different parts of the nation, whether it's from Kings County, Washington, or Storm Lake, Iowa, of all places, or Enid, Oklahoma, Dubuque, and Salina, Ohio. So there's larger communities that are growing on those places. And just like us in Arkansas, they're trying to kind of figure out the needs. How do they address the needs of that growing population? And not just in the healthcare fields, but also in education-wise and housing, and how do we address that? Because they see that there's a growing population. So there's a group that's planning to come and visit Northwest Arkansas at the end of the month, coming from Storm Lake, Iowa, to kind of see what we do in trying to address the needs of our Marshallese community here. And they're going to be visiting UMS, the regional campus, our Office of Community Urban Research, and some of the Marshallese community-based organizations who've been serving the needs of the Marshallese folks, our Marshall Islands Consulate and community clinics. And so they're coming in to kind of see firsthand, how do we address the needs of the Marshallese folks? And hopefully they can adapt it go back to Storm Lake, Iowa, or wherever they're coming from, any other groups, and basically adapt it to the needs of the folks there and what they can provide, but make it more culturally appropriate, understanding cultural humility in that aspect.
We've learned a lot about the Marshallese community just by talking to you today. What are resources? What do they look like? And what are available for healthcare providers that want to learn more, that may need to adapt and grow their practice to help their patients?
I think it depends on which state you are in. There's like, I know definitely there are some resources for Marshallese and Micronesians in Washington State and in Oregon and in Hawaii and even in some of these places in Iowa and Oahu. But I would say seek into those community-based organizations first. If this is available in your state, then I would say at least partner with them. Find at least one community-based organization who's willing to help you deal with that. Thinking of at least hiring a person of that culture into your practice or into your organizations to be your community champion who can help you and your institution navigate through that. If you do not have any of that locally, of course, all of us here in Arkansas, whether it's at UMS or some of the other community-based organizations, are more than willing to kind of help make those connections. I know we all work together with other groups in different states as well, because it's more about us trying to make sure that our families, and like I mentioned before, family is key for us. So we want to make sure that our families and communities in whatever states they are well taken care of and have their needs being addressed.
And federally qualified health centers like the Community Clinic in Northwest Arkansas play an important role in addressing the needs of vulnerable communities like the Marshallese. Tell me why and tell me about your work there with the Community Clinic.
Absolutely. I think, federally qualified healthcare centers are a blessing to many of us, especially to vulnerable communities who have issues in trying to access different resources in the community. And, FQACs are basically safety net programs, basically addressing the needs of those who really need it the most and doing it comprehensively. And, it's upon them through their funding through the federal government that there's supposed to be a comprehensive resource to those vulnerable communities. And even if those who do not have any health care or health insurance, they've always been there on a sliding base scale, offer medical, pediatrics, women's health, mental health, dental health. I mean, you name it. They've been trying to kind of work with that. If not, then they collaborate with other local resources in making sure that the needs of the communities that we serve are addressed. And that's what I see here with the community clinic in Northwest Arkansas. It's part of the reason that's where I practice my clinical medicine over at the community clinic in Springdale, because that's where I see all my patients. And it's great to see them walk in, and when people walk in, and the waiting room is filled with Marshallese patients talking story and talking in Marshallese, and they're talking to the front desk person who's Marshallese, and they walk back to the exam room with the Marshallese medical assistant. So I mean, it makes it more like a family atmosphere. It makes it easier that people are more willing to kind of be honest in what they're talking about, addressing their needs, and just kind of talk like they're back in the islands. So I think if QACs are a blessing to many of the populations, but at least community clinic in Springdale and other parts of Northwest Arkansas, because there's others, they really address the needs of the Marshallese and others who are vulnerable.
Well, Dr. Ricklin, I've learned so much today, and I'm so appreciative of the advocacy education that you provide to our viewers and across the state, and it reaches so many other homes all the way to Washington and Iowa, across the country. Thank you so much for all that you do for the Marshallese community and for Arkansans, and thank you for joining us today. It was such a pleasure to talk to you.
Thank you. It was an honor to be part of it.
Today I have with me Kenya Eddings, and she is the Executive Director of the Arkansas Minority Health Commission. Kenya, thank you so much for being here.
Thank you.
So tell me about the commission and what it does.
Sure. So the Arkansas Minority Health Commission was founded more than 30 years ago by Dr. Joycelyn Elders, and our mission is to provide equitable access to all minority Arkansans for healthcare preventive health screenings. The overall goal is to reduce cardiovascular disease and bring those numbers down, and we know that when we help minority Arkansans, we're helping all Arkansans. So that's the overall mission of the Arkansas Minority Health Commission.
And what are the biggest health disparities, health issues that you're seeing facing Arkansans?
Oh, wow. Where do we start and how much time do we have? Well, we do know that heart disease is the #1 cause of death for all Americans. We also know that heart disease is the #1 cause of death for minority Americans, specifically African Americans. So there's much work to be done as it relates to, trying to reduce hypertension, blood pressure rates, blood sugar rates, cholesterol rates, all those things that go into heart disease.
And your group does a lot of screenings, health fairs, that sort of thing. Tell me a little bit about that work.
Absolutely. So the Arkansas Minority Health Commission serves all 75 counties. We make it our mission to visit all 75 counties at least once in the fiscal year. So I'm proud to say that last fiscal year, we were able to service all 75 counties at least once. Now, what does that mean? We have a mobile health unit that's really popular. It's in high demand, and we take that mobile health unit, which has 2 full-size exam rooms on it, all around the state, performing preventative screenings, as I mentioned, blood sugar, blood pressure, cholesterol. We can do all sorts of other screenings like HIV screenings. We've partnered with UAMS to distribute FIT kits to test for colon cancer. We have a variety of partnerships, and we take those partners on the road with us when we can, so that we can help to reduce those chronic disease risks around the state.
Well, I have no doubt that you're reaching and saving lots of lives, I'm sure, from
Yes.
corner to corner.
Literally from corner to corner, yes. And our mobile health unit travels 3 days a week. So for 1 week, we'll be on the road Monday, Wednesday, and Friday of 1 week. And then the following week, we'll be on the road Tuesday, Thursday, Saturday. So we're somewhere all the time.
And if someone wanted to find where you were going to be next, how do they do that?
They can check out our website, arminorityhealth.com, or they can go to the Arkansas Department of Health website and click on the link that says Arkansas Minority Health Commission, or they can give us a call at 501-686-2720.
Lots of resources out there.
Lots of resources, and we're happy to help.
So let's talk a little bit about additional resources and things. So the commission helps with transportation and has different programs.
So we don't help with transportation, and I'm glad you brought up transportation, because with Arkansas being such a rural state, transportation is an issue for people to get the access to the health care and the preventive screenings that they need, which is one of the reasons why our mobile health unit is so popular, because we know that some people are homebound, some people don't have cars, some people don't have access to public transportation, and so we're literally able to meet people where they are by bringing our mobile health unit to communities, parking at a grocery store, parking at a school parking lot, parking at a church parking lot, go into a park, and people can actually come to us. We go to them so that we make that access. We level the playing field as it relates to access.
So it's not just urban areas too?
No, rural areas we go. As a matter of fact, I just thought about in June, for Juneteenth, we were down in Wilmot, Arkansas. We were also in Earl, Arkansas as well, providing those preventative services, literally meeting people where they are so that they could have that access.
And let's talk, aside from transportation, let's talk about food deserts and,
Sure.
and what your organization does for that.
Sure. So we were honored to be a part of, #1, Governor Asa Hutchinson's Food Desert Work Group. And then after that, we were able to be a part of the City of Little Rock's Food Desert Task Force, helping to address and solve the issues as it relates to food deserts. We know that Arkansas now has at least one food desert in every county. And, that's a problem. And so we are doing the research that it takes to figure out why we have these issues and how we can address those challenges. We know that for most communities, a brick and mortar grocery store is not going to be the answer for them anymore. Lots of people, they're used to the brick and mortar grocery store. They want the brick and mortar grocery store to come back, and we get it. But for a lot of communities, that's not going to be the right solution for them because of a variety of reasons. But we've done the research, we've done the development, we've gone on field trips to visit other states and other partners to see what they are doing without brick and mortar stores. And there are some novel ideas out there, some novel solutions, and we were able to bring those to Arkansas recently and host an inaugural Food Desert Summit with the Arkansas Hunger Relief Alliance, and we got tremendous response. And I think that some of those solutions communities are going to be able to use to take back to their community so that that access can be there. Access to healthy food can be there for the community.
And when you say brick and mortar, what are the alternatives? Is it at food pantry?
Oh my gosh, there's so many alternatives out there. So one of them is called, it's basically a mobile food grocery store on a truck. And so this is a company a nonprofit out of Memphis, Tennessee. And so this particular nonprofit purchased basically an 18-wheeler truck for all intents and purposes and converted it into a mobile grocery store. So what they do is they visit various neighborhoods throughout the week. They park it for 3 or 4 hours. They let the community know that they're going to be there in that food desert, and people come and they do their grocery shopping on this converted 18-wheeler truck. The beautiful part about it is not only it's wheelchair accessible too, so it's ADA compliant, so those who are bound to wheelchairs or have other physical ailments can still access the grocery store. It's a grocery store. It's just not in brick and mortar. So that's just one of the solutions that was brought to bear in this particular summit.
What a neat idea.
Oh my gosh, so outside of the box. And when you get people to thinking that, you know, there are other ideas out there, let's just look at them and see how it may work. And I know that there were a couple of communities there who were at that particular summit. The light bulbs, you could just see the light bulbs go off and say, hey, this might work from our community. Let me take that back.
Well, tell me a little bit about the Food Alliance with the City of Little Rock. That's a neat program too.
So the Arkansas Hunger Relief Alliance, which is currently led by Kathy Webb, she's also vice mayor. She partnered with the City of Little Rock, and then we were also able to partner with the City of Little Rock on the Food Desert Task Force, along with other public, private organizations, as well as several residents in the city to be a part of the Food Desert Work Group, because we want all parties who are affected and who can make an impact at the table. We want to hear from the neighbors. What concerns do you have? How can we help? What do you see as the future of this food desert for your community? And then bring in those experts too to kind of help facilitate conversations, do focus groups, ask questionnaires. And so from that, we were able to think about, you know, some solutions for the community.
Let's switch gears just a little bit.
Sure.
And since we're back in the middle of a school semester, and we are still coming off the heels post-COVID,
Yeah.
and one of the concerns I'm hearing is vaccination rates among kids and families. Are you seeing issues with that in minority communities as well?
Yeah, so there's been historically some reticence for vaccinations for obvious reasons. We know what the history is, but we encourage people, not just African Americans, but all Americans, everyone, to talk with your healthcare provider, to learn about what vaccination or what immunization is going to be right for you, your family, your child, so that the whole community is protected.
As Black populations do have the highest infant mortality rate as well in the United States, and I know your organization is also doing a lot to kind of shape that as well in Arkansas.
Absolutely, absolutely. And so we know that not only is infant mortality high for African Americans, but maternal mortality, morbidity, and mental health are through the roof for all moms, and particularly for African American moms. And so doing the necessary work that it takes to help raise awareness, raise education, and then putting in programs that will help to reduce those numbers. I'm really proud of the work that the Maternal Mortality Review Committee is doing to kind of help address. They study all deaths, all mothers who pass away within 1 year of giving birth. They study that. Why did it happen? How can we put in some programs to make things better, to reduce that risk? And the same with infants. It's called PQRC, Perinatal Quality Review Committee, that has just been implemented in Arkansas. And they're doing the same thing with infant mortality. So I think with those two combined, we can really make a difference. And I'm really glad that people are starting to be aware of the death rates, of the morbidity rates, of the maternal depression rates, because let's just face it, it's been here for quite some time. But now, we're finally shedding the light on the issue, and I'm hoping that we can reduce those numbers as we move forward in the future.
And you mentioned infant mortality too. Is this breastfeeding come into play with that as well, and education programs for that?
Absolutely. And we know that breastfeeding rates among Arkansans is not as high as we'd like it to be as we are compared to others around the United States. But we know the benefits of breastfeeding for both mom and baby. A lot of times, moms and adults just have not made that connection that breastfeeding can not only help the baby, but it can help mom. And there are so many benefits. It helps to reduce type 2 diabetes. It helps to reduce certain types of cancer, breast cancer, ovarian cancer, and it also helps mom to shed those unwanted baby pounds so that she can get back in shape. But the most important thing I think it is that it gives mom the satisfaction to know that she is giving her baby the best start in life if she breastfeeds or when she breastfeeds. And that's beneficial for baby. We know that the American Academy of Pediatrics recommends breastfeeding and only breastfeeding for babies unless there's something medically necessitates that the baby not breastfeed. But we know that breast milk is best.
And are you seeing a difference within minority communities, some hesitancy to not breastfeed? Is that what studies show?
Absolutely. There is hesitancy, and there are a variety of reasons why. Again, we go back to history, but we learn from history, and we take the research that comes in through what we're currently doing, we apply that to history, and we say, hey, we go out to communities and let them know, although this is what happened in the past, here is how breastfeeding can help you and baby. We know that for a lot of minorities, African American women, that historical context is there, but moms have to go back to work. There's not a lot of time off so that she can bond with baby, so that she can, express milk, then store it up. She has to go back to work. And so those stress factors, having to be on the schedule, having to take the baby to daycare, having to run the family household, things like that just kind of put breastfeeding on the back burner. But we want to let mom know that this is just as important and try to help her figure out ways to do it. Maybe she can express her milk at work. There are 2 laws on Arkansas's books that protects a woman's right to breastfeed. 1, she can breastfeed in public. And number 2, she can use her paid time at work to go and breastfeed or express milk for baby. So we know that those laws are on the books. It's just a matter of educating the public and educating the community.
And it's not just Black communities as well.
Exactly.
You see it in rural communities across the state?
Absolutely, because again, it's the education part of it, it's the access, but we know that there are programs like WIC that are out there that really help to support mom and baby, women, infant, and children. That particular program helps to support, and also with WIC, there are peer counselors, breastfeeding peer counselors, moms who have breastfed, who know what it's like, who can provide that support to new mothers entering the WIC program and just be there as a resource. We also know that SNAP is also a resource for mothers as well. So there are a variety of resources out there, but still there's so much more that we can be doing and that we are doing to kind of help.
And your research is also showing that that white adults in rural areas have a steadily rising early mortality rate too. Why is that?
That is a good question, and I think that if we all knew the answer to that, we'd be millionaires. But I think that some of the problem is that, some of the challenge is that access to healthcare, access to the preventive services, which is why it is so important that we lean on our local health units. There are at least one local health unit in each county. Some counties have more than one. There are community health centers around the state that provide that access as well. We know that, hospitals are closing down for a variety of reasons. Again, like we mentioned earlier, transportation is an issue for a lot of people. When we have the food deserts that have come about, combined with the access to the preventive health care, preventive screening, that affects everyone. And so we see the morbidity and the mortality rates rise as a result of that, because chronic disease rates rise as a result. And again, like we mentioned earlier, heart disease is the number one cause of death for all Americans.
So it's addressing health, economic, and geographic disparities. I mean, all of those things come into play for what your organization does.
Absolutely. And I think that the beautiful part about our mobile health unit, which again travels to all 75 counties, if someone wants our mobile health unit to visit their county or their neighborhood, just give us a call, 501-686-2720. But again, bringing the access to communities, and the Minority Health Commission has a mobile health unit, but there are also other organizations and nonprofits around the state who also have units that can be dispatched and deployed into various communities.
So really incredible programs and things that you guys are doing. Before we go, tell me what's ahead. What do you want our audience to know about what's ahead for the commission, and where do you see the next step is? What is it?
Oh my gosh, there are so many things that we're doing at your Arkansas Minority Health Commission. It's not ours, it belongs to the entire state, because we don't turn anyone away. So again, our primary thing is providing and making sure that all minority Arkansans have access to preventive health care, preventive screenings. But not only that, servicing everyone. We don't turn anyone away. Our big thing right now, and it always has been, is cardiovascular disease risk. We do that through a number of ways. We have our mobile health unit that travels around the state, but we also have a number of other programs, like our really, really popular Southern Ain't Fried Sundays cookbook and meal plan. It is a 21-day plan that is designed to help us to prepare our favorite comfort foods in a different way so that we can reduce that cardiovascular disease. We can reduce cholesterol, hypertension, blood sugar, just by changing the way we eat. A whole big thing now is food as medicine. And so we know that what we eat impacts how we feel and can impact our numbers. So we have that Southern Ain't Fried Sundays meal plan and cookbook. We also have something for the kids too. It's called Camp I Can. It's a 3-day summer day camp for kids ages 9 to 12. We focus on physical activity. We focus on kids in the kitchen, doing a cooking demonstration and exercise with them. We do yoga, and we've partnered with Recycle Bikes this year to provide a bicycle for each kid as well as a helmet, so then getting that physical activity. For some kids, this summer was the first time they've ever had a bicycle. And I mean, I'm getting goosebumps thinking about it. But being able to stand in the gap and fill the gap for where that access is not there is our whole mission. And that's what we're most proud of.
Changing lives across the state.
Changing lives across the state, absolutely.
Well, thank you so much for being here.
Thank you for having me.
Thank you for the incredible work that you're doing. I've learned a lot today, and not only that, but to seeing that it's Arkansans in all types of areas and communities.
Absolutely.
Really amazing work. Thank you.
Thank you for having me.
Sure. And that's it for this episode of AFMC TV. Have a great day, and thanks for watching.
Today I have with me Dr. Jason Bailey, and he is a board-certified pulmonologist and critical care intensivist, and he joined the staff of Northwest Health in 2021. Dr. Bailey, thank you so much for joining me today.
I'm happy to be here.
So tell me about this new procedure tool robot.
So this is a highly advanced robotic bronchoscopy that was developed by Da Vinci. With this high-tech equipment, we can reach the very peripheral parts of the lung and biopsy very small lung nodules. It's very good in diagnosing early stage lung cancers.
And it is minimally invasive comparative to other procedures?
Yes, that's correct. Versus a transthoracic needle biopsy, that's high risk for pneumothorax, a collapsed lung. With this device, we just go through the patient's oral airway down into the lungs, navigate the bronchial tree, reach into the far aspects within the lungs to reach these lung nodules.
And what are the risk factors for the procedure?
There is a risk of collapsed lung. However, it's much lower than if they were to have other procedures to diagnose these early stage lung cancers. And of course, we are taking tissue, so bleeding is always a possible complication, but we have ways to control that well, and of course, infection. But despite the possible risk, we hardly ever see these risks that develop after the procedure.
And is there a quick recovery?
Yes, the patient goes home the same day.
Oh, wow, that's much faster than say a traditional biopsy.
Yeah, if they were to have surgery, then they would be here for several days to, a week.
And tell me about how an ultrasound is also used during the procedure.
So we use different modalities to locate the lung nodule. You can get lost very easily navigating the bronchial tree. So we use ultrasound. We also use fluoroscopy, not to mention that we're using the CAT scan that's uploaded to the robot to navigate the bronchial tree. So as we're navigating down and we think we're at the lung nodule, then we use an ultrasound to locate the nodule to be sure that we're in the right place. And then we also use fluoroscopy to also locate the lung nodule to ensure that we're in the correct place before we start taking biopsies.
And there's a pathologist during the procedure as well?
Yeah, so as we're collecting tissue, we have the pathologist there that's also looking at the tissue that we collect underneath the microscope. And once the pathologist says, yeah, we have diagnostic tissue, then we start collecting as much tissue as possible so we can get all the testing that we need to make an accurate diagnosis.
And so how are you potentially diagnosing and staging the patient at the same time?
So after we do the robotic assisted bronchoscopy and collect as much tissue as we can from this lung nodule for diagnosis, then we can also use ultrasound to ultrasound the lymph nodes within the mediastinum and stick a needle in any enlarged lymph nodes for staging purposes. And so we are accurately diagnosing and staging the patient all within one setting.
So this is good for high-risk patients?
Yes, because it's minimally invasive and because it's very low risk, even patients who are on a lot of oxygen, we can still do this procedure on, and they have good results. They still usually go home the same day. The procedure itself is about between an hour and 2 hours, and we're not making any incisions or anything like that, minimally invasive. And so even with high risk patients, it's a low risk procedure.
And so how is this different from, say, a traditional lung cancer screening?
So it's two separate things. This is not a screening test. It's more of a diagnostic test. So patients who are high risk for cancer, patients with a long history of tobacco dependence, they should have a screening CAT scan every year. And with the screening CAT scan, if a lung nodule is picked up, then we can do this procedure where we upload their CAT scan to the robot. The robot helps us navigate the bronchial tree down to the lung nodule, and we take several biopsies of the lung nodules for diagnosis. So it is separate from screening. It's not a screening tool, it's more of a diagnostic tool. And of course, we stage them as well.
And results are a lot faster.
We're able to get patients in very quickly. If their primary care doctor calls us today saying we have a patient with a lung mass, we will see them early next week, Monday or Tuesday, to get the workup underway. We work patients through the system very quickly, so they can get the diagnosis as quick as possible, so they can get their treatment as quick as possible. With cancer, it's patients will have a lot better prognosis. Their mortality rate's much lower if we diagnose their cancer early.
And is this just for patients in Northwest Arkansas?
No, we'll take patients from anywhere, assuming they're willing to drive to us. And so, yeah, we take all different types of insurance, and as long as they can get here to us, we will work them up and get them diagnosed and staged.
And Arkansas is considered to be a hotbed for lung cancers, lots of smokers. Can this potentially make a big difference?
Yes, absolutely. We are diagnosing cancers earlier. We're able to reach hard to reach lung nodules. It doesn't matter if the lung nodule is close to the heart border and close to the pleura or close to the major vessels. We are able to reach it with this equipment. And because of that, we don't have to wait as long to get them diagnosed.
And are you the only physician in Northwest Arkansas doing this procedure?
As of right now, I'm the only one in this whole area that's doing this procedure.
And what are you hoping that our audience will learn from this? And can they refer patients to you? Can any physician refer patients to you?
Absolutely. Any physician can refer patients to us. And I would like for them to know that we can get them in very quickly, and we will shuffle them through the system to get them diagnosed as quick as possible and right back to their physician.
Well, Dr. Bailey, I've learned so much today about this unique procedure and all that you do, and we're so grateful for all that you do for your patients and the technology and in healthcare in our state. So thank you so much for being here today.
Thank you.